Post-streptococcal glomerulonephritis is an immunologically mediated schilla or pharyngitis or skin infections caused by Streptococcus pyogenes nephrogenic strains. It is a rare kidney disease that can develop after group A strep infections. There are three types of infections: strep throat, scarlet fever, and impetigo. It is not a group A strep infection, but is caused by the body's immune system fighting strep throat, scarlet fever, or impetigo. It typically develops 10 days after the onset of strep throat or scarlet fever symptoms. PSGN develops approximately 3 weeks after the onset of impetigo symptoms. The most important way to avoid PSGN is to avoid group A strep infections. Even though most people who develop PSGN recover without complications within a few weeks, serious complications such as long-term kidney damage are possible. Long-term kidney damage, including kidney failure, is uncommon. Children are more likely to develop these uncommon complications than adults.
PSGN incidence has decreased significantly in developed countries such as the United States, United Kingdom, Central Europe, and Japan over the last 3 decades. The use of antibiotic prophylaxis and the improvement of hygienic conditions are the reasons for this progress. PSGN has become more common in adult patients suffering from chronic debilitating diseases in these developed countries. It is more common in developing countries due to increased skin infections called pyoderma. Though the incidence has decreased in developed countries, it remains the most common cause of glomerulonephritis in children in the United States. PSGN is also the leading cause of kidney injury in children throughout the Middle East, Africa, Australia, and the rest of the world. In developing countries, the annual incidence of new cases of PSGN ranges from 8.5 to 28.5 per 100,000 people. Around 97% of PSGN cases are reported in developed. PSGN is not contagious because it is a delayed sequela of Group A strep infection. People, on the other hand, most commonly spread Group A strep through direct person-to-person transmission. Transmission typically occurs through an infected person's saliva or nasal secretions. Asymptomatic carriers are far more likely to spread the bacteria than symptomatic carriers. Congested areas such as schools, daycare centers, or military training facilities facilitate transmission. Although uncommon, Group A strep infections can spread through food. Foodborne pharyngitis outbreaks have occurred as a result of improper food handling. Historically, environmental transmission via surfaces and fomites was not thought to occur. However, evidence from outbreak investigations suggests that GAS transmission via the environment is possible, albeit. Symptoms and signs of post-streptococcal glomerulonephritis. Symptoms of PSGN can include malaise, abdominal discomfort, backache, sore throat, febrile, dark reddish-brown urine, edema, especially in the face, around the eyes, and in the hands and feet, decreased need to pee or decreased amount of urine, and fatigue due to mild anemia, feeling tired due to low iron levels in the blood. In addition, someone with PSGN usually has protein in the urine and hypertension. Some people may have no symptoms or symptoms that are so mild.
Various tests are conducted to produce the laboratory results needed to diagnose John. First test is CBC. CBC, or complete blood count, is a common and basic blood test requested and is used to evaluate your overall health and detect a wide range of disorders. John's CBC results shows us that white blood count and platelet count are under the normal range, but for hemoglobin, it is a little low, which tells us that the
So next test is comprehensive metabolic panel. It is also known as serum electrolyte test. It is a group of routine blood tests that measures levels of the body's main electrolytes, some of which are albumin, sodium, potassium, chloride, and urea. The laboratory findings that's on the table shows us that a patient's sodium and chloride are under normal range, which is good, but for albumin, which is 31, and it is below normal range, and it may be a sign of kidney or liver disease. Because albumin blood test is used to see how well your liver and kidneys are working. If your liver is damaged or you're not well nourished, your liver may not make enough albumin. If your kidneys are damaged, they may let too much albumin leave your body through peeing. So for potassium, it is a little above normal range, and potassium blood test is used to monitor or diagnose conditions related to abnormal potassium levels. These conditions may include kidney disease, high blood pressure, and heart disease. For his urea, it is above normal average. Blood urea nitrogen test measures the amount of urea nitrogen in your blood. Urea nitrogen is a waste product that your kidneys remove from your blood. And if you have higher than normal BUN levels, it may be a sign that your kidneys aren't working well. Next test conducted is urinalysis. So macroscopic hematuria is visible upon visual inspection, and that means that there is visible blood in the urine causing it to be discolored. Glucose and ketones are negative, which is good. White blood cell is also present, but it is under normal range because if it is higher than 10 cells per milliliter, then it might indicate infection. 24-hour urine protein test is also under normal range. And this test checks how much protein is being spilled into the urine, which can help detect disease such as glomerulonephritis. Urine culture test is also under normal range, and it is a test to check for germs or bacteria in your pee that can cause a urinary tract infection. For John's creatinine clearance, it is under normal range for a male. The creatinine clearance test is an older test to check your kidney function. This test allows your healthcare provider to look at samples of your urine and blood to see how much of the waste product, creatinine, is filtered out by your kidneys. Next test is culture from throat swab. Throat swab culture is done to identify germs that may cause infections in the throat. So we tested positive for Streptococcus pyogenes. Streptococcus pyogenes is a species of gram-positive aerotolerant bacteria in the genus Streptococcus. Pyogenes infections can result in the post-infectious sequela, acute rheumatic fever, and post-streptococcal glomerulonephritis. Moreover, it causes invasive infections like necrotizing fasciitis and toxic shock syndrome that is associated with and high morbidity and mortality. Next test conducted is anti-streptococcal antibodies test, and it is composed of 3 titers. So first is anti-streptolysin O titer, anti-DNase B titer, and anti-hyaluronidase titer. Anti-streptolysin O titer is a blood test to measure antibodies against streptolysin O, which is a substance produced by group A Streptococcus bacteria. Anti-DNase B is a blood test also to look for antibodies to a protein substance produced by group A Streptococcus. So John tested positive to these 2 tests, and it indicates that John is exposed to a group A Streptococcus and have had a recent strep infection. For anti-hyaluronidase titer, it is a test to diagnose glomerulonephritis. John tested positive for this, and a positive result in these tests indicates that John has strep infection. For the last test, it is complement blood test. It gives information about your immune system. It shows how parts of your immune system are responding to harmful substances. John's result for serum C4 is under normal range. So complement component 4 is a type of special protein that is found in the surface of a certain cells and in blood plasma. These complement proteins help to fight viral and bacterial infections and rid your body of dead cells and other foreign material. As for your serum C3 results, it is below normal range. So lower than normal levels of C3 proteins can be a sign of autoimmune disease, Based on the laboratory findings of John, we can hypothesize that John has post-streptococcal glomerulonephritis. This is supported by the following. First, evidence of a preceding streptococcal infection is determined by positive results on anti-streptolysin titer, anti-DNase B, and anti-hyaluronidase titer. Second, serum complement level C3 is usually low due to its consumption in the inflammatory reaction. Third, renal function tests such as blood urea nitrogen or BUN is also elevated. Urine analysis shows macroscopic hematuria, red blood cell and white blood cell casts, granular cast.
The pathophysiology of post-streptococcal glomerulonephritis is that the condition is immunological and is an incidence of type 2 hypersensitivity. The precise method by which PGSN or post-streptococcal glomerulonephritis takes place is not yet fully understood. Immune complexes containing the streptococcal antigen and human antibody are developed by the body in response to nephrogenic.
Some theories suggest that these immune complexes become deposited in kidney glomeruli reaching through the circulation. Others claim that the condition results from an in situ formation of the antigen-antibody complex within the kidney glomeruli. This in situ immune complex formation is either due to a reaction against streptococci antigens deposited in the glomerular basement membrane or, according to other theories, due to an antibody reaction against glomerular components that cross-react with streptococcal antigen due to molecular mimicry. The presence of immune complexes leads to the activation of the alternate complement pathway, causing infiltration of the leukocytes. The proliferation of the mesenchymal cells in the glomerulus, thus impairing with capillary perfusion and glomerular filtration rate. Reduction in GFR or glomerular filtration rate can lead to a renal failure, which is oliguria or anuria, acid-base imbalance, electrolyte abnormalities, volume overload, edema.
As for John's case, there is no further laboratory testing required. During the week of medication, his blood pressure already dropped to 105/70, and there are no signs of proteinuria nor hematuria. Several weeks after presentation, his C3 levels are returned to normal. And lastly, after his follow-up checkup, there are no signs of renal impairment for John.
The pathogenesis of streptococcal glomerulonephritis results from a bacterial infection that causes rapid deterioration of the kidney function due to an inflammatory response following streptococcal infection. PSGN most commonly represents in children 1 to 2 weeks after a streptococcal throat infection or within 6 weeks following a streptococcal skin infection. When symptomatic, PSGN typically presents with features of the nephrotic syndrome such as hematuria.
Case Study 1, question number 2. What is seen if a renal biopsy from this patient is stained with anti-immunoglobulin G and anti-C3 antibodies conjugated to fluorescein? Answer is, on immunofluorescence, the immune deposit causes a starry sky, granular appearance along the glomerular.
Prognosis. The majority of children with PSGN recover completely within 6 to 8 weeks, but complete recovery is uncommon. It can take up to 12 weeks for symptoms to improve enough for a child to resume normal activities in some cases. PSGN is usually followed by clinical recovery that lasts several days to weeks, and the long-term outlook is generally considered excellent, with no increased risk of urinary abnormalities or hypotension. However, some studies have found an increase in chronic renal impairment following this illness. In adults, approximately half of patients still have impaired.
Are all strains of Group A streptococci equally pathogenic? Group A beta hemolytic streptococci are pathogenic due to them having the ability to produce streptolysin, an enzyme which complete lyses red blood cells near the bacterial colony called beta hemolysis.